All right. Well, I'm Tylan Magnusson. I'm a medical oncologist over in Eastern Idaho. I practice in Rexburg and Idaho Falls. And today we're going to be talking a little bit about how we plan for survivorship at every stage, because how we approach survivorship changes based on whether we're seeing a patient for the first time or if they're further along in treatment. And there's so many aspects to think of, and every patient is very, very different and has very unique needs, as we've seen already from these cases. If you could progress slides. So our learning objectives today is to understand why and how survivorship planning requires multidisciplinary care, understanding how the various elements of survivorship plans interconnect at various stages, and understanding some of the common pitfalls to survivorship planning. Go ahead and progress slide. So cancer outcomes have improved dramatically over the years, and we now care for a rapidly growing population of survivors. A lot of these people will live years or even decades after their diagnosis, and that's a new thing from not that long ago. What's important to recognize is the majority of their long-term care happens outside of oncology. And so while these patients are seen by our clinics and everything, we're not good at a lot of the other stuff. And a lot of our approaches to making their life better and longer happens outside of our clinic and is outside of my scope of knowledge. Survivorship's inherently a team sport. We don't deliberately design systems for coordination, or if we don't, patients experience fragmented care. A lot of things, toxicities can be missed, things that happen, decades and decades after that maybe they're not seeing an oncologist no more for. This conversation is less about creating new work and more about aligning what we already do for patients, so they have a little bit more continuity instead of constant handoffs by utilizing our resources earlier. Next slide. A cancer survivor begins at the moment of diagnosis and it continues all through treatment and surveillance and long-term follow-up. The definition of survivor matters because it reframes survivorship from being a phase previously thought of kind of, something that happens at the end of treatment to being a layer of care that runs across the entire disease trajectory. So when we adopt that perspective, we begin anticipating those late effects earlier, involving people that can be helpful in their care down the line earlier so that they already have a relationship with those people. And then, with that mindset, we set better expectations earlier on as well. Sometimes when we have a new diagnosis, we get really wrapped up in what to do about it next. What are the emergent things happening? And if we don't establish some expectations for what's going to come next, then it feels like a surprise when they're done with treatment and they find out there's a whole lot more to this and a whole lot more to do. And that can be kind of traumatic. So it's important to involve broader care team earlier. And we have a lot of research evidence showing that ultimately improves both patient confidence and their outcomes in many measurable ways. Next slide. So there's a lot of reasons why we aren't so good at survivorship care. A lot of these challenges don't necessarily happen because clinicians or other members of the team lack expertise. They usually happen because care becomes fragmented, especially in a lot of rural places in Idaho. Maybe a patient doesn't have access to a lot of the resources that they might in a bigger city. And patients are constantly moving between oncology and primary care, therapy services, various subspecialists, medical and surgical, and often no one clearly owns the overall roadmap for that patient. And it can be very different based on what the diagnosis is. So without very intentional communication, a lot of important issues like cardiotoxicity risk, decline in their function status, psychosocial distress, all of that kind of falls through the cracks when somebody assumes that another person's taking care of that problem. So survivorship planning is essentially about closing those coordination gaps so that patients and providers, family members, community members have a similar understanding of what to watch for and who's responsible for what throughout their life. And again, that evolves over time. These survivorship plans have to be flexible. They have to change over time with the changes in the patient's needs too. Next slide. So a survivorship care plan is really best thought of as like a roadmap. At a bare minimum, you'll have kind of a summary of the diagnosis, treatments received, late and long-term effects, recommendations for surveillance, and then some key health promotion recommendations, things like surveillance for other cancers and things like that that can be influenced by what the patient's clinical course is. But it also should clarify to some degree, who to call for which types of concerns. Do I expect that this late toxicity is something that I can take care of as an oncologist? Sometimes, but more often it's someone else that's better at those things. So when we're good at this, it supports both patients and clinicians by reducing a lot of that element of uncertainty, and making shared care a lot more efficient. So of course the goal is not paperwork, it's communication. It's being able to establish these relationships earlier on in the patient's clinical course so that when issues or questions or problems arise, there's kind of already a plan in place and rolling at that time. Next slide. So instead of thinking about survivorship as something that patients graduate into, it's more accurate to think of it as like a layer that runs with treatment and long-term follow-up. Patients receiving active therapy are still experiencing survivorship issues, things like, fatigue, employment concerns, anxiety, discussions of what the rest of their life looks like, and addressing those issues early improves recovery and quality of life. These plans and these discussions are things that happen continuously. When I see a patient for the first time, I try to set some level of expectations for what their disease course looks like. But oftentimes people aren't ready to hear that, or they don't really want to know that. They're just focused on getting started and addressing the cancer as early as humanly possible, and they're just not worried about those other things at that time. And that's okay. Whereas some other patients, maybe people who are otherwise kind of sick at baseline and really not looking to dive into another major health thing, and would rather focus on comfort things. Maybe that's sometimes what we focus on first encounter. So even though cancer's most often the biggest issue going on in their life when they have that new diagnosis, we sometimes we just need to step back and realize that survivorship is not always about just living longer. And again, we revisit this during their surveillance period. Sometimes a patient will really be struggling through treatment and will get through it with a lot of supportive care and such. And then all of those problems go away and their needs change very differently during their surveillance period. Maybe, like the patient in the case, maybe, after negative biopsies, positive biopsies, and all this trauma of going through all of that, those thoughts are constantly on a person's mind. Every new headache that they have, any new pain anywhere. It always goes back to that cancer, and it becomes a lifelong stressor for them. And then, of course, during recurrence or progression, typically by the time we're seeing a patient, if they like a recurrence later in life, sometimes the treatments or the expectations have evolved a lot since they first were diagnosed. So sometimes the patient will come in saying, I don't really want to go through this again. And lo and behold, there's a lot better options that are much better tolerated at the. So it's just something that's kind of layered throughout their entire clinical course from diagnosis to the end of their life, and it's something that has to evolve over time. Next slide. So comprehensive survivorship care spans many domains. Of course, what I'm taking care of typically is that small role of medical surveillance for recurrence and late effects. Then we need help with physical and functional health, cognitive and emotional well-being, psychosocial and practical needs, health maintenance, and really no single discipline can cover all of these alone. It really has to be coordinated, multidisciplinary engagement from the get-go. Each of these domains continuously changes in importance throughout their lives, with one thing occasionally taking precedence. For example, sometimes we'll have a patient going through their medical treatment. Let's say they have a pathologic fracture of one of their bones. They need to recover from that before they go through treatment. And then let's say their insurance changes halfway through, and now we're having to pause all of that while we figure out them to financially afford that, and kind of in the background, they're dealing with, family collapse from all of the stressors. So these things are, it's like if you've ever been to a circus, you can imagine those guys spinning all the plates on the top of the sticks, and you kind of end up sometimes just spinning whatever plate's closest to falling, and just waiting for the next thing to fall and focusing on that. But you really have to continuously refocus what your goals are with the patient. Next slide. So when we think about follow-up care, recurrence monitoring is really only part of the story. That's what I'm familiar with, of course. My job is to be looking for the cancer and trying my best to spot these other things and get the patient to the right person if they develop. But a lot of patients will face long-term risks such as cardiotoxicity, endocrine dysfunction, neuropathy, other cancers. And sometimes these will present first in their primary care or a hospitalization. Or, I've had patients refer whatever you can imagine with suspicion for recurrent cancer. And that's thanks to all of these people, all these cogs being in motion for the patient. Uh, so having clear documentation of treatment exposures and risk-based screening recommendations helps ensures that these issues are at least identified early when they do happen. Um, what we try to do is sometimes a patient will have a specific treatment that has some expected long-term side effects. For example, some of the immunotherapies we use will cause all sorts of permanent endocrine dysfunctions with the pituitary or the adrenal glands or what have you. And sometimes those things go really under-recognized. And so making sure that the patient is aware that these things are possible down the road and to bring it up at future appointments if they're ever having issues or if they're ever admitted, that sort of thing. Just I guess normalizing their cancer history, a part of their personal history. Next slide. So functional decline, fatigue, pain, and deconditioning are among the most common survivorship issues we see for sure. But they're also some of the most treatable when they're addressed early. So early referral to rehabilitation and therapy services can significantly improve independence, reduce a lot of the complications we see, as well as accelerate recovery. Survivorship planning helps normalize these referrals as kind of a standard of care rather than late interventions. In most cases, uh, some of these more fragile patients, in order to be even able to receive some of the treatments, need to be physically intact and so it's not just about getting better and feeling better. It's about being able to tolerate things that could potentially cure them or keep their cancer under control. And so their physical well-being is one of the best indicators we have for how well a person's going to tolerate a therapy and their long-term survival. So really, these therapies, these services should be thought of as part of a standard treatment plan for the diagnosis, just like chemotherapy might be. Let's say I have a new frail patient, maybe kind of borderline for whether they can receive therapy, getting them connected with the people that can help them to restore their function status is maybe just as or more important than the, specific cancer-directed therapies. So from the get-go, with a lot of these diagnoses, we have to think about all of those additional services as part of their routine cancer treatment period. Um, Next slide. So cognitive changes all across the spectrum, anxiety, depression, all of these things are extremely common and often under-recognized. And more often than not, this is an area that we struggle with as oncologists pretty severely. Oftentimes we'll have a patient that has this new diagnosis, and you expect some level of anxiety, some level of depression, grief, and we're often not good at differentiating what's normal, a normal response to what maybe we could be treating better. When we proactively are screening and normalizing these experiences, we improve the quality of life, but we also help patients to remain engaged in their medical care. It's easy for people that are going through a terminal diagnosis, especially, to just kind of shut down, and that can have major detrimental effects on their family life and how their family will remember them. And so if we're able to engage them and recognize when these things can be helped with whatever services those might be, you can really make a difference, not just for the patient, but their family and community. Major, major difference. There's also a lot of identity shifts that happen. In our men, for example, with prostate cancer, we have to give them these medications that will completely deplete their testosterone, so they see their body change. They see themselves gain weight and lose muscle mass, and it can lead to a major identity crisis. Also, women after a breast cancer diagnosis going through mastectomy, looking in the mirror and seeing yourself be so different than what you always expected. It can really cause a huge crisis in a lot of people. And that's reasonable. So we have to normalize that to a little bit, but also help patients recognize that, there's a lot of other people kind of going through this life and how to make the best of that and how to make this new life that they have good. Next slide. Survivorship also includes all the practical realities of life after diagnosis. There's employment problems, finances, changes in family roles, sexual health, caregiver strain, and all of these factors influence outcomes, but are rarely addressed without, really deliberate attention. Social work, behavioral health, and supportive care services can play a critical role in helping patients navigate all of these challenges. For example, we had a gentleman not too long ago, 50s or 60s, who had recurrent colon cancer, and his he didn't have a lot of cancer, but when he was very first diagnosed, the way that they framed it, it was almost celebratory. We're going to cure this. This is going to be fine. You're going to get back to work. And so ultimately, over the year that followed, this family went into bankruptcy for all of these things. He wasn't able to work for a lot of the time. They were really, really, really struggling. And then his cancer came back, and all of the expectations, all of those feelings of, hey, we're financially destitute now, but at least I'm alive. At least things are going well from a cancer standpoint. All of those good things vanished, and they were left with an absolute crisis. And that was a major permanent issue with their family. And he elected not to pursue further therapy because of that hopelessness that he felt. And so this can have major lasting impacts that we sometimes don't think about early in the process. Oftentimes, as an oncologist, for example, we're writing these orders and we're kind of ignorant to the expenses accumulating on the other side. Um, and then these other things like sexual health, dependence on caregivers. These are things that sometimes just kind of go unaddressed unless the patient brings it up. We're often just not very good about asking the right questions to explore these things, fortunately. Next slide. So health promotion is one of the highest impact areas of survivorship care that we could possibly do. Things that are high impact in patients without a cancer diagnosis, things like smoking cessation, exercise, nutrition counseling, getting their routine vaccinations, and other preventive screening. Yeah, really meaningfully reduces long-term morbidity. A lot of these interventions are most effectively delivered in a primary care and community settings. I'm not always even up to date on what vaccination people need to be on such, and it just really reinforces the importance of shared responsibility on these patients. Uh, for example, we have a lot of breast cancer patients who require all sorts of different hormone therapies for lifelong. They can have a lot of weight gain and things like that, and we found that uh, their obesity is a predictor of breast cancers that occur, and so many of the other things that we do. So we prescribe these medications that cost hundreds of thousands of dollars for small percentage decreases in recurrence for these diagnoses. And then all along, maybe we could have made a better impact if we spent some of our time and energy talking about these other very routine things, weight loss, smoking cessation, things like that. All of those things maintain their importance in cancer patients. We also get a lot of patients who might have really well-controlled cancer, whether it's curable or not, and they're years from a diagnosis, and then behold, we kind of forgot about their smoking history, we forgot about their routine lung cancer screenings, and then we find something that way, or sometimes we neglect those other routine things like breast cancer screening, prostate cancer screening, lung cancer screening when we're dealing with another problem. And if we expect our patient to live long, well, when appropriate, we can't forget. Next slide. So in practice, these survivorship care plans often fail when they're too long, they arrive too late, or they're too static and unwilling to change. So a concise, actionable plan that's delivered early and is updated periodically with as expectations change is a lot more useful than a lengthy document created at the end of a treatment that's never revisited. So being having it be accessible and usable are key. Sometimes things like several brief if-then statements can go a long way to guide other members of the team towards an appropriate evaluation of a new symptom or other change in health. Some of our chemotherapies are really cardiotoxic, and so having as part of their survivorship care plan a recognition that in 20 years, if patients reporting these symptoms, we need to look for this, things like that. Next slide. So the most help typically include kind of a concise summary that has, estimated dates of when things happened, roughly what happened, any surgeries, radiation, and other cancer-directed therapies that happened, and then helps other providers to recognize red flags that might come up for later effects from the treatments that they received. It should call into a reminder for different surveillance intervals that may be required in the short term and long term following their cancer diagnosis, as well as some clear instructions on who to contact for specific concerns. Simplicity increases the likelihood that this document will actually be used by both patients and clinicians. So having something that both patients can look at and understand, and pass on to their primary care doctor, pass on to their therapists and other members of their team is really important. It's just got to be understandable and actionable. Next slide. It's also important to recognize that the goals of survivorship care change across the disease spectrum. We might have like an early stage, highly curable cancer where they're going to go through a brief period of time that's just very, very intense with lots of different treatment modalities. They might have a lot of symptoms of their treatment. They might not be thinking long term at that point. And so, focusing on those things at that period of time in their life. And then in patients that might not have curable disease, making sure that the treatments that we're giving are actually giving them better length or quality of life, and not just treating the disease. And then, of course, ultimately, most of our patients, we're taking care of them throughout their end of life period as well. And so making sure that they're comfortable. Uh, and that they're comfortable with the legacy that they leave, and that their family's also ready for it. Oftentimes what I've tried to do, especially in cancers that have kind of a poor prognosis, part of their plan is getting their affairs in order. With that first visit, establishing a little bit of rapport, but immediately helping them to recognize that this is something that could take their life soon. And their spouse needs to know their passwords and account. Uh, Making that a normal part of those very difficult early discussions. Next slide. So things that non-oncology providers can do now, when you see someone ask about their cancer history, everyone plays an essential role in survivorship care. Screening for late effects, addressing preventive health needs, and then communicating findings if something's if something just seems off, just communicating that back to oncology. That strengthens our shared care. These small steps can really significantly improve continuity for patients, and help them get through this. Next slide. From the oncology perspective, we really rely on our colleagues to help monitor some of these long-term health issues, provide feedback when new concerns arise, and engage in closed-loop communication. Survivorship works best when ownership is shared rather than transferred. When I quote unquote discharge a patient from my office, that doesn't mean that their whole cancer history just evaporated. They still went through a lot, and there might be things that come up down the line, even if they're less likely, and maybe they don't necessarily need to see an oncologist regularly for it. That's still part of their medical history, and is likely to come into place sometime later in life. There's also so many things that are constantly changing, new mutations that are found that might increase family risk. So their family history can also have an effect on their cancer history too. Next slide. So to kind of sum, survivorship ends at the diagnosis. Survivorship care plans are tools for coordination rather than just paperwork, and effective survivorship care depends on multidisciplinary collaboration. Every discipline represented here plays a critical role in helping patients live well after cancer. The last thing we want is for a patient to get through these complicated diagnoses and the rest of their life be suffering from the consequences of it. A lot of people will regret treatment at that point, and we want to do our best to avoid that situation. Success of cancer care is no longer just measured in survival, but in how well people live afterward. And without the help of a team, we cannot make that happen effectively. Uh, and then the last slide is just references. Any questions?
Tylan, thank you so much. Oh, we could just stop the share. If you have any questions, you're welcome to raise your hand. If there's questions in the room, please do so as well, or you can use the chat. And I have a question to kick us off a little bit. Can you tell me a little bit more about the overlap of survivorship care planning and advanced care planning?
Lots and lots of overlap. Sometimes with survivorship care planning, we get a little bit of our blinders on, and not wanting to incorporate some of that advanced care planning. But advanced care planning is an important part of survivorship. There's a lot of unpredictability in survivorship. A lot of times we can't anticipate everything, and so incorporating advanced care planning very, very early on helps people feel a lot better throughout their cancer course. As a personal anecdote, when my dad was diagnosed with really advanced esophageal cancer, it was really good that we got some of the advanced care planning stuff taken care of early, because ultimately, when he declined really quickly, my mom and him were able to just focus on him and his health, and they weren't stressed about getting those account numbers and stressed about getting all the people taken care of and all that. They were able to just focus on being together. It's important to frame it like that sometimes, and help the patient recognize now may be the best you feel for a little while, and we really need to take care of these things just in case things go poorly.
And a good reminder for all of us who are otherwise healthy to be doing that stuff anyways, too.
Absolutely.
Good call out, Sam. Thank you. What other questions or comments do we have in our last couple minutes for Tylan? Uh, any other? I have one more question, Tylan. I'm just thinking from a patient perspective, are people surprised by just the concept of survivorship care planning, or is this something within their support groups or other groups this is being talked about?
Um, I think it feels natural to them for the most part. Oftentimes they're getting bombarded by family members and even their other doctors and stuff about, hey, what's the plan with your cancer? What's to expect? And oftentimes they just don't remember those details, so they'll write them down. They'll come back with a bunch more questions. And instead, if we were being included better at providing with some of that information and what to expect from treatment, what other needs you're probably going to have earlier on, then I think their family members, their community, and their other healthcare providers be a little bit more ready to rally behind them. So patients appreciate it overall. I think it just makes it a lot easier for them to communicate with other people too.
And I would add in, I think when I see folks who have good care planning and kind of know what to expect with their treatment, it can reduce a lot of the anxiety, a lot of the fear, and a lot of the chronic pain risk as well, too. Because I think a lot of times, to the point earlier of like once these people are going back through routine surveillance and they don't really trust their body anymore, man, they just everything is a 10 out of 10, or you can see some people it'll really drive them through the roof. So the more ahead of time I think we can give people that information, the better they manage their entire health spectrum beyond this as well.